Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello, I'm Yuda Henrosman. I'm an endocrinologist in private practice with a focus on metabolism. Specifically, I manage obesity and diabetes and in the prevention of comorbidities. In the past 8-10 years, recognizing the important role CKD, kidney disease, plays in the development of cardiovascular disease and heart failure and general metabolic health, I made treating and preventing progression of kidney disease a priority. I address general health and traditional risk factors like hypertension and dyslipidemia. I manage and I'm adopting the 4 pillars approach with combination of ACE-ARBs, SGLT2 inhibitors, finerenone, and nonsteroidal MRA, and GLP-1 receptor agonists. It is my pleasure to welcome you all to this program entitled Primary Care Strategies for Reducing Cardiovascular and Kidney Risks in Diabetes. Joining me today is Dr. Xavier Cos, who is a primary care specialist since the late 90s with a PhD in diabetes care. Xavier is also an associate professor at Universitat Autonoma de Barcelona and chair of primary care diabetes Europe. He has been actively involved in clinical research in primary care, including clinical trials, both drugs and technology, publishing many epidemiological big data research, consensus documents, and guidelines. In the past years, he has also participated in common initiative with KDIGO on behalf of PCD Europe. He has been teaching and publishing about CKD and primary care role in first early detection and clinical management. A very warm welcome, Xavier.
Thank you.
So, in our program today, what we'd like to show is discussing that in recent years, following the obesity epidemic, we have witnessed an explosion of diabetes, of which approximately 40 to 50% may have CKD. In general, CKD and type 2 diabetes are very common and very serious. However, the awareness is very low. At least in the US, 1 in 5 people with diabetes don't know that they have it. Actually, I think that's an overestimation how many people know that. And 9 of 10 people with CKD don't know that they have it. And also, minorities and older people have proportionally higher issues with kidney disease. I wonder, Xavier, how is it, in Spain and in Europe in terms of awareness?
I think that is an area of improvement, clearly. Some of our patients, they don't know they have diabetes. We know this is around 50% of them. For example, we have data from Spain where we have a total prevalence of 14%, and just 9% know, 5% don't know. So probably 30% don't know about they are type 2 diabetic persons. And in terms of CKD, the figures are very similar. I think it's important that healthcare professionals understand the importance to test the kidney on those clinical situations where we know that the kidney must be a target, also for consequences of the morbidities, and also to screen and to detect and early detect if anything is happening in the kidney.
And I agree. So I think that some of the targets that we would have with this particular program is to raise awareness among primary care physicians who are the first really to see the patient to be able to diagnose whether they have diabetes, whether they have kidney disease. The reason that we can diagnose today is because we can treat. Can you expand on that a bit?
There are new drugs working properly on persons living with chronic diseases as diabetes and also having some signs of chronic kidney disease. So I think it's important because we know that there's a lack of specific symptoms of CKD. We know that this is a disease, also diabetes, that is a little betraying because the person, they don't feel anything against. When you feel something that's a consequence of the disease, I'm sorry, that we are probably too late. Okay, so it's important that we be proactive. For that reason, it's probably a lack of disease awareness. And I think also this is a responsibility of healthcare professionals when we are coaching those persons living with chronic conditions like diabetes to help them to understand that diabetes is not just, we have to pay attention, sugar. We have to pay attention also of the consequences of having high sugar together with high blood pressure, lipids, etc. And the reason to be treating that disease is because we are just trying to avoid the chronic complications and the micro and the macrovascular complications. So it's important that, of course, that puts on the agenda of healthcare professionals the utility of using UACR. We need to explore function and damage. And a disease like diabetes can produce problems in the function of the kidney, that it means a decline of AGFR, and also damage. And that it means that we are starting losing proteins, albumin, and then we have very easy tests we can try to incorporate in terms to do an screening. And that must be a proactive action. We need to be more proactive on those patients that we know that are high risk to develop CKD, and of course, persons living with diabetes and hypertension, two diseases that are highly correlated with having consequences in the kidney. We have to do this proactive screening approach. And I think that is a very strong message for all healthcare professionals in the primary care setting, that they have to put on their agenda that kind of tests when they would like to know what is the situation, how healthy is the kidneys on that person they have in front of them with chronic conditions.
So you seem to be very knowledgeable about it, and you seem to be also passionate about the need to do this kind of screening. Why do you think primary care physicians are not aware like you are aware?
I think it's important to keep in mind that in primary care, we are trying to deal not just with diabetes or one index disease. When persons came to our clinic, they came for 3 or 4 different reasons. And that it means that some specific aspects are probably diluted on the relevance of that things. And I think that's why it's really important that when you have in front of you a person that is living with a chronic condition, we need to be proactive. We know we have to test A1C twice a year to know how is the metabolic control in type 2 diabetes, if the person is under control, if the person is really well managed, if the A1C is on target. But we have other situations that we need to do a proactive screening. That it means we have to test the heart. Of course, we have to explore the foot. We have to explore also the kidney. We have to explore also the retina. And also, all this is the different aspects as a potential complication we need to be in a proactive manner to assess. And of course, I think when you have a solution in a more clear manner, and we have now medications that help us changing probably the journey of this complication, that could be very helpful to detect that situation in early stages, and that we can provide solutions as early as possible. Why is so important to embrace a holistic interdisciplinary approach toward risk management for patients with CKD and diabetes? What do you think is this holistic interdisciplinary approach?
I think that we need all to recognize that we no more live in silos. In medicine, except for the primary care specialty, I mean, we all were in silos. We were just focusing on one disease, on one treatment, on one solution. And our patients don't live in silos. As you mentioned, they have a lot of issues that you need as a primary care physician to solve, not just one issue. But we recognize in recent years that there is a lot of interaction in that what I call the metabolic milieu, where we are looking at people that have obesity and diabetes. They typically would have high blood pressure, they will have lipid disorders, but they also have kidney disease, and then they have cardiovascular disease, and they have heart failure. Cardiovascular disease is common in type 2 diabetes. Cardiovascular disease is much worse in a person who's got CKD and type 2 diabetes. And CKD and kidney disease and heart failure are very tightly connected. And what happened was that 10 years ago, the study called EMPA-REG uh, showed that a drug for diabetes called empagliflozin was able to not just improve glucose, but actually reduce mortality. And later on, we saw that it's a treatment for heart failure. And then we saw that it's a treatment for kidney disease. All of a sudden, one drug takes care of several aspects of disease. So we need to know what our drugs are doing. We cannot anymore do what you said before, glucose just, lipid just, blood pressure just. We need to have a comprehensive care, and we need to recognize how our medications affect our patients. How do you see that in Europe?
One important aspect that you just mentioned is that when we are detecting that complications or that risk, we have in front of us the possibility of stratify individuals in different stages. That means that we have to be very proactive on those at higher risk. We need to put special attention on those ones that are probably young or adults below 60. We have many diagnosed type 2 diabetes and already with hypertension, and we are start observing problems in kidney, in heart, of course, because we know that it is ones that have more life expectancy, and we have to be more proactive in the approach. And when we have a person with microalbuminuria and other things, the risk, as you already mentioned, is higher. And that means that our action, and that already we have plenty of evidence, a steno-2 trial, other ones, projecting that an holistic approach of all the factors is going to be beneficial. Of course, UKPDS projects the most glucose metabolic, but steno-2 trial on individuals that are high-risk individuals already with micro complications, with albuminuria, already project these benefits. So, of course, when we are testing, it's because we have solutions and because that testing allow us to stratify the risk of that individuals. Probably we don't have to offer the same to everybody. We have to niche our efforts on those ones that we know that needs more our attention.
What we started to recognize, though, and it's so true what you're saying, and we started to recognize that the earlier we intervene, the better the patient will be. We used to take our time, we still take our time, but there's so much data now in hypertension that if you intervene earlier, you prevent more diseases. In lipids, the earlier you get, the faster you get to goal, the less complications. Same with glucose. In other words, there's a continuum of risk that we are seeing, and it's not just jump in buckets. It's a continuum. So as an example, we can see here that people with CKD, how important it is to identify it early on. Let's look at hospitalization. As we go down with estimated GFR, as we go more advanced in kidney disease, the more people will be hospitalized. As we go up in kidney disease, the more people will die. And then same thing with CV events. Your experience?
I mean, I completely agree with that perspective and what you said. In my perspective, in my understanding, many of my colleagues are not really aware they are in 3B. And 3B is a higher risk situation. I mean, you have to be very proactive. It's not when you have stage 4 that you think, no, many medications are contraindicated, and then, you start probably you have to refer to the nephrologist, etc. No, excuse me, it's 3B, and between 3A and 3B, where you have a big portion of your patients, you have to be more proactive. These ones are the individuals where you need to paying attention.
And I want to add to that. It's, I mentioned EMPA-REG before, and we'll talk about some of the kidney trial that we have seen. But in EMPA-REG, they were all in CKD2. They were a kind of estimated GFR in the mid 70s. When we gave the SGLT2, it almost normalized the decline of estimated GFR. And it's interesting, and we know now that SGLT2 help the kidneys, and we've got more medication that help the kidneys. And I'll let you go and discuss how we do that. The earlier we intervene, the better outcome our patients will have.
Yeah. And I think that, for example, an important thing we've been discussing before is how we detect these persons. And probably many of us, we are using electronic clinical records. That one is alerting us when we have to do the testing. We need to do at least annually, at least when you don't have any previous problem. And then according what you're observing, you have a route map of what is the best approach when you have some kind of problems detected. I think it's important that, as we said previously, we are trying to move into a problem that is not producing any symptom, anything. We are just going to be proactive. And then, of course, when we are doing that kind of testing and we are diagnosing, doing 2 times, and all of these already validated criteria that allow to understand that you have to do it, the retest, to know that you have confirming that problem, you have to go to a specific tool that helps you to understand in what situation is the person you have in front of you. I mean, and then you have 2 things. You have the function, EGFR, estimation of the filtration rate, and the lab is providing you that parameter, or because you are calculating the CK-epic or Croft-Wall, and then of course the albuminuria, the albumin-creatinine ratio. And then of course you have this heat map that you have here that allow to understand in a very clear and easy manner what is the action you have to do in that situation. Wait another year and screen again in the green boxes, or maybe do some specific action starting with a medication, or maybe treat and consult, or maybe refer. It depends how your healthcare system is organized, because probably you cannot refer, but maybe you can consult, or you can do something else that allow to know if you are doing the proper management in that specific situation with that person.
So this KDIGO heat map, which kind of predict the risk of the patient, it's really based on very simple tools that every primary care physician can do. Look at estimated GFR, which is from the simple lab, from the creatinine, and then the formula ratio for that, and then look at some albumin in the urine. It is so simple to do, and do it once a year, and then plug it into this risk predictor called the heat map by KDIGO, and you can go forward with that. So what are the guidelines now that recommend treatment option for CKD? We mentioned KDIGO, which is this kind of a global kidney association that has been working together with the American Diabetes Association, so with diabetologists, kind of giving now a holistic approach for patient care. So we always start with lifestyle. We have always to remind our patient to keep healthy diet. They have to do physical activity. They must stop smoking. And it's clear that weight management is important. I have many patients who eat healthy, but they eat a lot of it. And when you eat a lot of healthy food, then you will gain weight, and that's not healthy. So we have to pay attention to that. And then we're looking at first line medical therapy. If you're a primary care physician, you can do it easy. These are medications that you know and you have them. So you start for metformin for glucose and SGLT2 inhibitors now, recommended very early on because it works to a point on the glucose, but clearly on the kidney and the heart, which we had to take into account, as a lot of those patients have blood pressure. They need to start on RAS inhibitors, and clearly, if they have diabetes, they will have to be on statins. I must admit that I use less moderate intensity, high intensity statin as what we do on our patients. I know there's a move in Europe, in England, doing the same thing. And then, it says second line, like GLP-1 receptor agonist, the newer class of non-steroidal MRA, specifically finerenone, that's been introduced and now approved to manage people that have CKD in type 2 diabetes. We probably do it earlier, some of us, especially if we need to control glucose in diabetes. GLP-1 will become much earlier. in the treatment, especially that it also has cardiovascular outcome. And then there are a lot of patients that cannot tolerate SGLT2. Some cannot tolerate GLP-1. We must address the kidney. The non-steroidal MRAs are very good option in that setting. And by doing this kind of a holistic approach as recommended by KDIGO, we all of a sudden put on one page primary care physician, endocrinologist, cardiologist, nephrologist. We all can relate and use this kind of holistic recommendation to manage our patients. Dr. Koss, would you tell us what are the evidence? We discussed it a bit before, but can you discuss SGLT2 and CKD?
Yes, before moving to this, just keep in mind also Wonka, the World Organization for Primary Care, together with PCD, Primary Care Diabetes Europe, KDIGO, developed what is called one pager. That document that is in KDIGO website is prompting the primary care community how to be concerned what is the important aspects in terms of testing and actions, and explain in a very clear and easy manner how to do the screening and then the management. In terms of the question, it's a very common and clear message, crystal message. All the different studies, the Credence, the DAPA-CKD, EMPA-Kidney, that test the potential benefits observed when these medications were tested on cardiovascular outcome trials start providing a glimpse, an idea of a potential benefit of that compounds in the kidney. So I hear is very clear and consistent. The three different compounds, canagliflozin, dapagliflozin, empagliflozin, project in a clear manner benefits when they've been confronted in a trial against placebo in a composite primary endpoint, observing benefits that goes around 30% in terms of risk reduction of that renal endpoint or cardiovascular death. So I think it's important to keep in mind that all these compounds as a family have benefits in the kidney. So that's why I think it's consistent what you said before. The idea of using that compounds is important. But of course, always the primary community must be informed about the potential side effect of any medication. Something important to keep in mind due to the mechanism is probably you can have hypotension because you are doing an osmotic diuresis, and you have to keep in mind when you are using hypertensive compounds if the person is also under diuretic medication. I think the most important thing is genital infections of the urinary tract. It's a class effect. I think they could be prevented when you inform the person about that situation, providing the appropriate advice and inform that could happen, not stop medication, and probably come to the clinic to provide a therapy, and that could be solved. And the other situations are more rare and probably could be scaring and producing noise, but I think it's important to keep in mind those ones I already mentioned.
Well, I think it's very good what you said. We've got the SGLT2 in practice way over 10 years. We found them to be very safe. They don't cause hypoglycemia, only if they're maybe with insulin, and even then it's very little. A lot of the list of side effects was early on when they came. We don't actually see them. We have to be cognizant that they can happen, but as you said, quite safe. The genital infection is probably the primary one that need to be paid attention in the elderly, specifically maybe looking at the hypertension sometimes can happen. So GLP-1 receptor agonists also help the kidney. There was a recent trial, it's called the FLOW trial, with semaglutide, and it showed to first improve kidney function, and then it also reduced death from any cause, which is a very tough thing to do. So managing the kidney is critical, and what's good is that all these drugs can work together. So adverse effect of GLP-1 receptor agonists, we know them. It's primarily nausea, diarrhea, occasional vomiting. That's the main one that we're seeing. Sometimes even constipation. We stop the drug, they go away. Rare occasion instances of pancreatitis. Safe drugs again, lots of benefit, but some side effects that are troubling, but would be okay. So when we are looking at the non-steroidal MRA like finerenone, let's talk about the efficacy of the drug. So there were a couple large trial in diabetes, Fidelio that looked on impact on the kidney, and then what was the secondary cardiovascular outcome. And then Figaro, similar trial, look at impact on cardiovascular disease, and then what was impact on the kidney. Put them together into Fidelity, and what we see is that there is a 14% cardiovascular risk reduction, statistically significant, and there is 23% reduction in progression of kidney disease, statistically significant. So here we are, non-steroidal MRAs, which are different than the old type MRAs. They're totally separate. We know that spironolactone and others are pretty good drugs. We use them in blood pressure. We use them in heart failure with reduced ejection fraction. They have a lot of side effects, especially, for men specifically, some sexual side effect of gynecomastia and so on. This new class of the non-steroidal don't have any one of those side effects. They do have some issues with increasing potassium, just like the older class, but not as much. So if we look at these studies, we can see that there was just about a 1.7% increase of potassium compared to 0.6% that led to discontinuation. Otherwise, we can see elevation of potassium, but this is relatively easily manageable. So we mentioned that before, and I'd like to take your input on that about the proposed, and it was primarily a nephrologist by George Bakris, who was really behind these four pillar ideas. The four pillar was developed for people with heart failure, reduced ejection fraction, because their mortality was 50% in 4 or 5 years. And by doing the four pillars, we could triple the lifespan. So George came out with the four pillars for managing people with CKD, giving RAS inhibitor, SGLT2 inhibitors, non-steroidal MRA, and GLP-1 receptor agonists in various degrees of urgency. How would you address that, Xavier?
I think that what Professor Bakris recommend is completely aligned with what I think is now the evidence projecting. And he said to you because they already know about the evidence and have plenty of sense to try to see how this could be implemented. Because the important thing is moving from evidence to the adoption. And I think here is probably what we try to do with that educational activity, try to create awareness to help and coach our colleagues, our peers, in terms to understand how these four pillars are essential in the management of CKD at the moment, because it's projecting what is the best evidence available. Of course, moving from what you are doing to a new situation always is a challenge, because it means that you incorporate new knowledge and new ways of operating and new ways of understanding the disease and new ways, and that needs to create a space in your brain and in performance. Understanding that we have now medications that are modifying the journey of the disease in the kidney, in the heart is clear. We know that we are not deemed to be a step back on that. We have to be together in that alignment and trying to see how we can adopt, as I say, these as solutions.
And right, and so this leads us like to the multidisciplinary care in CKD. And what we have learned that in any mono treatment, there's always a lot of residual risk. But when we treat in combinations, the steno, already 15, 20 years ago, we learned that when we do combination therapy, we get a much better outcome. This is what we have to learn now, and we discussed it before, that if we will look in multidisciplinary care, the primary care physician, the cardiologist, the nephrologist, these medications that we have today help the kidney, help the heart, help the glucose, help the blood pressure, help the whole patient, and that's how we should take it.
Fully agree. I think we have to move into high value based care actions. That it means to stop doing what is not beneficial and to put our attention and focus on those ones that have benefits. If we are testing, it's because we know that there are solutions. As I said, we are saying this continuously in this program. And I think it's because we have solutions, we have to act providing solutions for those situations that we are detecting that require that solutions. So I think that schemes that we are combining medications, we know from 20 years ago or more, where we started combining insulin with oral agents, combining different orals. So we are not anymore switching. We are doing add-on therapies. We are trying to see how these different medications are providing benefits in the different mechanisms of the diseases, or the comorbidities we have. And then I think it's important that we are following that approach. It's more updated and is more aligned with the evidence we have available, as I said.
Do you want to tell us a bit about George?
Yeah, this could be George, Anna, Michael is an example of a person we can have in our clinic in the primary care. So actually, is a patient of my clinic. So he's a 54 years old, working in a financial division in an industrial sector, have a lot of hours working. Normally, it has been difficult to engage him to come to the clinic, to be honest. That is one important thing. You have to work a lot in education, allowing the person to understand that he must be committed and responsible of his disease, and we are just going to coach and to help, but he must be the owner of this situation. Okay, and I think it's very important just to not the patients to deposit the responsibility in our sides. We need to work as a team, and I think this is an example of a young person, hypertensive, dyslipidemic, type 2 diabetic for some years already, and also have a family history cardiovascular disease. So this is the actual medications, is irbesartan, 150 once daily, simvastatin, metformin, 850 twice daily. We have here the last A1C we have available, 7.5. This is an obese person with a BMI of 30. We have the blood pressure results, and we see that probably this person, although we have this initial situation, is far from the targets. Look at the LDL, okay, is far from what we really ideal. Also, blood pressure must be improved. Also, probably A1C is not really on the individualized target of a person like this. Probably we're trying to be lower than 7, not 7, or probably closer to 6.5, okay? And see what we can do with the medication. And the other things probably we need to know in the assessment is what's going on the retina, of any kind of neuropathy, the annual check testing for the kidney, and we observe the eGFR and the UACR, we observe these values. And these values also are, again, informing us that something else we need to pay attention. We just have already blood pressure not controlled, lipid not controlled. We have A1C probably require a more tight approach. But now we also have the kidney that is function, and also in terms of UACR, also some things to be done, okay? So probably in that perspective, of course, how we are going to stratify the risk in that person for the kidney. Of course, the heat map, positioning that person with that values in a situation that it requires attention in terms of treating, not just screening, treating, because we already observe damage. We observe already that this person is in a 3A stage, but close to 3B in terms of eGFR, but already is microminuria. So we need to start using probably a medication as a SGLT2 inhibitor. It will be my option, okay? But besides that, we have to also modify the lipid therapy, also probably move to irbesartan 300, okay, to try to improve blood pressure, and probably insisting with the lifestyle, observing what's going on with A1C. What do you think would be a good approach, Yehuda, in terms of a follow-up? Because we are now having this intervention. We now also observing problems in the kidney. We are going to go forward on that strategy. But what do you think could be a good approach in terms of follow-up of that person?
I agree with starting the empagliflozin, increasing irbesartan to 300 is important. He has CKD, so I'd look at goals of blood pressure less than 130, as close to 120 as possible. So you may have to give him another blood pressure medication on top of that. The SGLT2 inhibitor will not be enough. He is obese. You mentioned 6.5. That's obviously my goal. It's been for many years. So I think I'd probably consider giving the GLP-1 receptor agonist on him, which will help lose some weight, which will definitely control the glucose, may also help a little bit on the kidney. I think comes the question here, if you want to protect the kidney, I think by 3 months, you need to check again the UACR. I don't anticipate estimated GFR to change much, but you want to see the impact on the UAGFR and then consider adding finerenone. If you add finerenone, you just want to make sure that the potassium less than 4.8. I mean, if it's less than 4.8, you can start with 20 milligram. If it's more, then you can start with 20 milligram finerenone. But then you want to check it again in about, again, in my clinic, it would be in a month. In your clinic, maybe in 3 months. It depends when you can bring your patient back in. What's nice about the fact that we have SGLT2 inhibitor and finerenone together, that we see less hyperkalemia in that population. So that's the follow-up, I think, is important thing. Yeah, and don't forget what you mentioned is controlling the lipids. It's going to be tough on this patient. Okay, I want to just mention shortly, people with type 1 diabetes at a huge risk for kidney disease, heart failure, and heart disease. They don't have much medications for them. I know that in the primary care setting, that's not your primary patients, but you really need to know what's going on. And so far, the only medication that we have for them are the traditional one. There's nothing of the new one to help them. So there are studies coming up with future medications. So the finerenone is being tried now in patients with CKD and type 1. It's called FINE-1. We'll get the result in a few years. It's a very simple trial. Just look at people with type 1 that have CKD and see the impact on finerenone on them. Because finerenone has no glucose impact, we don't anticipate any complication in this population different from the other population. What else in people with type 1 is sotagliflozin. This is an SGLT1, SGLT2 combination. The drug is already approved for heart failure in the United States, so it's probably used by specialists. They're studying it in people with CKD, and we'll have to see how the result is. There is always the fear of DKA in this population, but those people that have kidney disease have by far less risk for DKA. That's just a little hidden secret that people don't know. So that's the sugar and salt study in people with CKD. Also, the same drug is being studied in people that have type 1 and heart failure. Again, same drugs work in different conditions. So that's a future. I think that there will be a need for the primary care physician to know once it gets to market. Okay, Davir, I'd like to thank you. Before we close, it was really terrific discussion. I don't know how come we did not meet till today, but it's a good time to meet and have a good clinical discussion. And so before we end, let's share a couple comments about the screening of CKD and the importance of what we discussed today.
Yes, thank you for very inspiring dialogue. So I think it's very relevant from the primary care perspective, the idea of early screening, because we have to do an early management. And I think this is very important. Screen and treat early, because we know the benefits of doing that. So put the kidney on your agenda when you have in front of you persons living with chronic conditions that are high risk of having kidney disease, like diabetes, for example. That's the index disease we are talking about. Of course, it's really important that we have available these tools, the eGFR and UACR. We know that some of them are not available everywhere. Okay, sometimes our lab is not providing the eGFR, but we can calculate that one easily with apps or their websites, CKEPI or Cochrane Gold. If you don't have CKEPI, you can do it, and you have an estimation of the function. In terms of the damage, probably is more challenging, but also I think the authorities and the healthcare providers are more concerned about the high benefit of having these parameters in the formulary of your lab. So I think it's important to keep in mind. And of course, last and not least, all the different medications and the relevance all of them have in the terms of the management of that individuals that are at risk. And I think of the RAS inhibitors, SGLT2 inhibitors, finerenone, and of course, what has been projected by the GLP-1 receptor agonists in that case with the flow study, semaglutide, providing the benefits in the kidney as well. So I think it's screen, treat early. What are the tools we have available, and that here we have the solutions, and that we have to use it.
Xavier, was a pleasure. We hope to meet again. I'd like to thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.